Good evening to you all. Myself, Dr. Raja Bandyopadhyay, and actually I am today want to discuss some of the essential questions in emergency medicine, as I am a faculty member of teaching and guiding the PGT in Department of Emergency Medicine and Radiology. So my earlier videos was for emergency radiology also, and now I will be discussing some typical question which are most frequently I do observe, which actually to 4 5 years like 4 5 years ago it came, and it is being repeated in emergency medicine. Now those who are doing MD in emergency medicine or DNB, they can be equally be benefited, and I will be discussing the GI emergencies with head and neck emergencies, and so it will be a part 1 type, GI and GI emergency and head and neck emergency, and then I will be discussing about urological emergency and CNS emergency in my later video. So just now I will be starting my question. Now this is actually very important question, and this is frequently asked in the exam also. Now and it has been quite for some time it has been asked. Now the question goes like this, that discuss the approach to acute pain in the ear. Now like a middle aged man, he came in the emergency department with acute pain in the bilateral ear, and how will you manage the patient? So unlike general medicine, what is the main cream of this emergency medicine is that you have to give the acute condition and acute diagnosis. Here the question will not be asked like a chronic question will not be asked, and neither it is being entertained in emergency medicine. So only acute cases are entertained in emergency medicine, as we all know. So here discuss the approach. Just a simple question, discuss the approach to acute pain in the ear. How will you manage that? Now just as a first thing, that acute pain in the ear can be caused by the variety of condition. Now such as otitis media, medial ear infection, and then otitis externa, which is known as swimmer ear, or eardrum rupture also, or foreign body in the ear canal. There can be this type of pain is very common, causing the otalgia. Now here general approach in evaluating and managing the acute pain in the ear is taking the thorough history. First we have to take the thorough history. Ask the patient, you have to ask the patient about the onset and duration of the symptom, and recent illness, previous ear problem, and allergies and medication. That you have to ask for the medications, and if the patient has any medication which is allergic to ear, then you have to perform a physical examination, inspect the outer ear and ear canal for the signs of inflammation. You have to take otoscopy, and you have to do the inflammation, you have to see the signs of inflammation, discharge and foreign body. And as I already told, we have to use the otoscope for that. And otoscopy is generally for checking the perforation, fluid or abscess. And then you have to consider the severity of pain. By the ear pain range from mild discomfort to severe pain. Severe pain like hyperalgesia it can be, especially if accompanied by fever, may indicate most serious infection that requires immediate medical attention. Now basically the patient who are admitted in the emergency department, or those who are doing their residency, they frequently encounter with this type of problem. So this is the most common question which is being asked. Now what are the common causes of acute pain in the ear? If it is a primary otalgia, if there are maybe infectious cause, mechanical cause, or there may be inflammatory changes or neoplastic causes also that can cause the pain in your ear. In acute physiology I am not going, because what is the pain mechanism, what is the pain mechanism that is triggered, etc. I am not going in the physiology, but there then primary otalgia, the primary or infectious causes are acute or chronic otitis media, then bullous otitis externa or laryngitis, acute auricular perichondritis, herpes zoster, that is the Ramsay-Hunt syndrome, malignant otitis externa. Then mechanical causes can be ET dysfunction also, that is estrogen tube dysfunction. cerumen infection, if there is a cerumen infection also later, if you the patient manhandles that, it may lead. And barotrauma also, there can be a barotrauma and hematoma of the pinna. Now inflammatory causes also chondrodermatitis, nodulosus helictis, that is also one type of disease which is managed by the skin people and the ENT people also, both. Then there is a secondary, there is a Wegener's granulomatosis with associated serious otitis media, or if there is any malignancy in the ear like squamous cell carcinoma, most common, followed by basal cell, melanoma and cholesteatoma. Now these are the actually the primary causes of otalgia. Okay. Now what are the secondary causes of otalgia? Secondary cause means there is some primary cause which is leading to the secondary cause of otalgia. So secondary cause of otalgia is head like temporary arteritis or like sinuses. If it is a sinusitis, nasal polyps, or if there is any disease in the TM joint, bruxism, salivary glands or sialadenitis or sialolithiasis, or if there is a salivary gland tumor rather. There is a oral cavity also, dental caries or other dental pathology. If related to dental, then you have to, in the emergency, the dental people also are there to look for the secondary causes. Squamous cell carcinoma of the tongue, thyroid if there is a thyroiditis or if there is a like thyroid carcinoma. Okay. Lymph node if there is a lymphadenopathy or lymph node malignancy, this is also one of the most important cause. And then the neuralgia if there is a secondary trigeminal neuralgia, glossopharyngeal, geniculate, splenomeningeal, vagal, occipital neuralgia, or if there is a pharyngitis, nasopharyngeal carcinoma, if there is a NPC, then also tonsillitis, pons tonsillectomy, laryngitis, or if there is a torticollis, cervical disc resolution, cervical retinopathy, various secondary causes are there which may trigger secondary otalgia. Now, you may ask a very important question that why the neoplastic causes are in the primary and why the another neoplastic causes are, because if it is a metastatic growth there, if there is a secondary tumor in the ear for any primary elsewhere, then it comes in the secondary otalgia. Okay, like squamous cell carcinoma, most common primary tumor in the ear, so it will be a primary otalgia. And if like suppose squamous cell carcinoma of the tongue, okay, and metastasis, most frequently metastasis is in the ear, so there can be, or lymph node metastasis, secondary lymph node metastasis, this can also be cause a secondary otalgia. So you have to explain and give, the question can confuse you and you have to give the answer, okay, accordingly. Now how you have to manage the pain? First you have to, in the emergency department, the question, basically the examiner, they want you the perfect knowledge about that what in the emergency department you should act upon. Now firstly you have to think upon NSAIDs, okay. Acetaminophen or brufen can be used to relieve the pain and reduce fever. See, we know everything. We know these things, how to manage and how not to manage. The basic thing is that how to approach these types of patients. That is the main thing they are expecting to see from you. Okay. Now, if the pain is severe, a topical anesthetic such as benzocaine should be applied to the ear canal. However, topical anesthetic should be used with caution as they can cause allergic reaction also. This is also a very important thing which you should know, and you should always treat the underlying cause. Now, antibiotics may be necessary if the pain is caused by the bacterial infection such as otitis externa or something like that. Antibiotics are not always necessary, and viral infection do not respond to antibiotics. In case of foreign body, ear canal remove part may be necessary, and there can also be like secondary if the patient is not is in a immunosuppressed area, then otomycosis is also one of the frequent cause which can lead to serious acute pain in the ear. So you have to know the etiology, you have to ask the patient, history is very much required, and thereby you can treat the patient. By then alleviating the pain, you can call the ENT person for necessary follow-up. But before that you have to do the first aid, because in the emergency medicine only the basic thing is cured. Now the follow-up patients with severe persistent symptoms, signs of like hearing loss or facial weakness, or those do not respond to initial treatment, should be, as always, it should be referred to a ENT specialist for further evaluation. It is important to note this is general approach and specific management will depend upon the individual patient, clinical presentation and medical history. As I told, so it will be dependent upon, if it is otomycosis, we cannot give any antibiotics. It will rather trigger, it will rather not alleviate the pain, it will rather stimulate the pain. Okay, so their antifungals are indicated. So in this way, the history is very important in this way. Unlike in general medicine paper, history is also important, but here history is only important, nothing else. Because in history only you will get the clue. Okay. Now, very important question again. I think it was asked 2 or 3 years ago, probably in 2023 DNB exam. Explain the assessment and the management of acute onset vertigo. Okay. Now, explanation to that question is, now what is vertigo? Vertigo is a common distressing presentation of the general practice and constitutes about 54% case of the dizziness. This is the main statistics which is given to us. And classically vertigo present with sensation of movement and describing around the patient. And often patient describes a spinning sensation of either the body is the surrounding, and this sensation can be confused with dizziness, which is non-specific term. Now the dizziness will be non-specific, okay? It will not be a specific one. The patient will come to you in the emergency department telling that everything in and around me are spinning and revolving. Now, so an adequate history is required. Again, the adequate history is required to differentiate this symptom. And dizziness can be classified into 4 groups. Now, how will you classify the dizziness? Okay. Now, the dizziness will be classified into 4 groups, which are vertigo, which is spinning sensation, then disequilibrium, that's feeling of imbalance, light-headedness, sensation of giddiness, and pre-syncope, sensation of feeling faint. And so, these are the 4 types of classification which you can get from the patient. If you take a good history, then you will get. So, vertigo can be classified as a central or peripheral on the basis of vestibular symptom pathology. Now, vestibular symptoms originating from the pathology in the cerebrum or brainstem are classified into the central type. Now, conversely, symptom arising from the inner ear or from the vestibular symptom are classified as peripheral. Now, what are the vertigo-based causes of vertigo, which is based on origin? Like, we have to divide by peripheral or central. Now, if it is like benign positional vertigo, it is in peripheral, whereas central is like, suppose if there is an infection or something like that. Labyrinthitis, if it is a neuronitis, it is peripheral. Meniere's disease, again peripheral. Otitis media, or if it is a wax in the foreign body in the ear, that is peripheral. And if it is a case of acoustic neuroma, then it is peripheral. Central, like stroke or vestibular insufficiency, subclavian steal syndrome, that is also there. Post-traumatic, if there is any post-traumatic, then there is a central involvement of the central nervous system, and there is a central cause of the vertigo. Or infection, if there is infection, as I told you earlier, like meningitis, or if there is a brain abscess. So now this is the thing. And first of all, the main thing, again, the approach should be again very practical approach, and the physical examination is must. It can assist in differentiating between central and peripheral subtypes of the vertigo, and examination involve the following. First of all, again, you should take an otoscope and perform and visualize the tympanic membrane for any vesicles that can be seen, like herpes zoster infection or retraction pockets, which can be seen in the cholesteatoma. Now, vertigo triggered by pushing the tragus with Valsalva maneuver is seen in the perilymphatic fistula, very common. A hearing assessment should be performed. In the emergency department, we have audiometry, and or like if we don't have audiometry, if there is no access to audiometry, we can do Renis or Weber's also there. Now, neurological examination initially focus on the neurological examination, including gait, balance, coordination need to be performed. Like again, Romberg's, okay, or heel to toe test, and examiners for cerebral signs include central cause. Now, eye examination is also very important. Now, eyes needs to be examined for the nystagmus and the papilloedema. And nystagmus is a quick, jerky, involuntary movement of the eye, and vertical symptom is only seen if the cause is central. And nystagmus, due to central cause, may be horizontal, rotational, vertical, and does not disappear on fixing the gaze. So here you can just think of that it can be due to eye. Then you can refer the patient to the ophthalmologist. Now, cardiovascular examination is also very much required, like pulse, blood pressure, heart, or ABC. Carotid examination or identify the broods at certain case of the cerebrovascular accident, like CVA. We have to rule out, and you have to also do the maneuvers, different maneuver to check if there is a secondary BPV, that is benign positional paroxysmal position vertigo. Now, it is the most common cause of vertigo in clinical practice and caused by the accumulation of calcium crystal in the posterior semicircular canal. Okay. Now, these crystals affect the movement of the endolimb in the semicircular canals, which cause vertigo. And the classic symptom of BPV are brief episode of vertigo associated with the nausea and nystagmus. These are the very classic symptoms in the BPV, and I think we can get doubt we can see by the physical examination. There are various maneuver, that is Dix-Hallpike maneuver. Now in BPV, in contrast, Epile maneuver can be used to treat BPV. This procedure is performed in an attempt to dislodge the otoliths from the semicircular canal. So this you should, if we manage this case in the emergency department, then it is okay, or you have to refer that patient by giving some sort of relief, and then the otorhinologist or ENT specialist will do the needful. Now, if there is a case of acute labyrinthitis, now if there is a case when this inner ear is composed of the bony and membranous, now what is labyrinthitis? So it is an inflammation of labyrinth. The inner ear is composed of the bony and membranous labyrinth. Acute labyrinthitis is inflammation of the labyrinth present with the vertigo and hearing loss and preceded by the viral infection. Sorry. Now, middle ear infection can spread the inner ear and can cause labyrinthitis. So this is the main the cause of the labyrinthitis, acute labyrinthitis. And the duration of the symptom ranges from the days to week, and hearing loss is the main distinguishing factor between the labyrinthitis and BPV. Typically in labyrinthitis, we no treatment we do for labyrinthitis. However, if suppurative labyrinthitis suspect, the patient should be referred to emergency department. Then we can do drainage of otitis media, and for just alleviating the symptom, we can give any anti-vertigo drug, starting from the CCBs and starting from the various anti-vertigo treatment. Vertigo are there, like beta-histine, etc. Now, if there is a vestibular neuronitis, this is also very important. If there is a vestibular neuronitis, it is caused by the